All right. I'm not. Could be.
No, you could.
Oh, okay. I'm guessing. Okay. Good morning, everybody. Welcome to Post-phaco Rounds. This is Kelsey Brown. I'm one of the staff pathologists here at Coplow, and I will be taking us through the first two cases. If I can advance the slide. There we go. Okay. Both my cases are fairly classic. Both of them are cats. Just trying to stay on theme here. So my first one is this one. This is the globe from a 13-year-old female spayed Russian blue mixed breed cat. And this eye, which is the right eye, was enucleated for an intraocular mass. This cat also had panuveitis in this eye, as well as retinal detachment. They said no to glaucoma, and they said the other eye was normal at the time of enucleation. They also gave us some general medical history, which I will withhold for the time being. So this image is going to be a gross image of the hemisected right globe that we received. Indeed, there is a mass associated with this globe. So it is appearing to involve the uveal tract, maybe mostly our ciliary body and choroid. It's kind of sneaking into the other kind of side here, also thickening this part of the choroid. It is also perhaps expanding our sclera. We can make out maybe a little bit of normal sclera right at the periphery, but it is very thinned and kind of pushed out or expanded by this tan mass effect. Other things, we also do have some kind of hazy vitreous. We can kind of see these little tan dip dots perhaps. And then this is our retina here, and it is indeed detached. Grossly, we'd also wonder if maybe it was a little bit thick. Sometimes when it gets folded up like this, it's a little hard to tell. There should be an optic nerve head somewhere here. It's just a little bit hard to see. I suspect it's just obscured by this mass effect, and maybe the globe's a little tilted. Okay, so we will go and move to our histo. I definitely have ready to go. And let's go ahead and start our subgross. Down.
Ooh, that's pretty. Ooh.
Indeed. Okay, so with our subgross, we have our cornea up top, and then our optic nerve head is back here. You can see a little optic nerve. So our cornea doesn't really have anything particularly exciting to point out at this low power view. We can see, so here are our iris leaflets. There may be a little bit more cellular. There's just more blue or purple within the iris stroma. There are also perhaps some cells within the anterior chamber here. As we move back, our lens is artifactually fragmented. This is all just artifact, not a true cataract. We can look at that more closely. And then going back to our mass effect, here she is. It's huge. It does indeed appear to involve mostly ciliary body and choroid. And then also we do have infiltration of the sclera. It's kind of hard to make out. Maybe there's a little bit of normal sclera at the limbus, and then most of it's just effaced by this mass. And it's a fairly purple mass, so there probably are a lot of nuclei here, so that makes us believe that is probably fairly cellular. And then in our vitreous, there is a lot of eosinophilic material, so our vitreous is somewhat proteinaceous, which probably imparted that hazy appearance we saw grossly. And then here's our retina. Again, it is indeed detached. There's some material in the subretinal space as well. All right, so now our globe has rotated 90 degrees. Our cornea is going to be to the right, posterior segment to the left. Please ignore this cover slip scratch. That is an artifact. All right, starting with our cornea, maybe the least exciting part of this whole globe. There is some stromal vascularization at the periphery, which is a fairly non-specific finding. There are some areas where the corneal epithelium, so here's our corneal epithelium, kind of drops out, which I interpret to be artifact. There isn't any stromal reaction, and sometimes it's a fairly kind of sharp demarcation between normal epithelium and areas where it's lost. Our corneal epithelium is really delicate, so just any rubbing of the corneal epithelium after enucleation can cause it to be artifactually lost. So even when we hemisect the globe on the cutting board, if there's too much friction, sometimes we can see just some dropout here and there of that epithelium. But again, not the most exciting part of this globe. So we'll move to our uveal tract and let's just go ahead and look at this mass. I've vamped long enough. As we move closer, maybe hard to make out who these cells are to start, but perhaps we can make out that it's a somewhat heterogeneous population. Sometimes we have these kind of smaller nuclei, and sometimes we have these larger cells with more open nuclei, maybe more cytoplasm. But we have the tools to go closer, so let's do that. Okay, so as I mentioned, mixed population. This is an inflammatory population making up this mass. So we have some plasma cells here. Occasionally we have these cells with maybe more condensed nuclei and less cytoplasm, so lymphocytes, some neutrophils with these little kind of squiggly segmented nuclei. And then the vast majority of these cells are macrophages. So we have cells that have abundant eosinophilic cytoplasm. They have these kind of more open looking nuclei, coarsely stippled chromatin. And as we move into kind of the center of the mass, it becomes even more macrophage rich. So this is a granulomatous, a pyogranulomatous mass, which in the globe of a cat should maybe cause us to think about some infectious diseases. And in some cases, we look and look and look, and it's really hard to find anything. In this particular case, it is a slightly more straightforward diagnosis. We saw this guy. Ooh. Ah. So I can direct everyone's eyes to this macrophage here. Within the cytoplasm, we have 3, 4, 5, 6, maybe 7, 8 organisms within the cytoplasm. They are round to oval. They're pretty small, like, I don't know, maybe 4 or 5 microns. And kind of hard to make out what's going on in them. There's kind of just this basophilic center and this kind of clear zone around them. So all of these things are going to be characteristic of histoplasma. You can kind of move around, see there's quite a few in here. There's more of them. Beautiful. And that's going to be the cause of this pyogranulomatous mass in this eye. Okay. Move around to show more of it. So on the other side of our globe, again, just similar inflammation, this time just within the choroidal stroma. It's mixed, and yeah, just tons and tons of these yeast organisms. They're kind of just everywhere. There's more right there at the bottom. This is a great case because we oftentimes don't have this very florid presence of yeast. Sometimes we'll see this pyogranulomatous inflammation in a cat eye, and we suspect it's histoplasma, but we just don't see any organisms, and we're left just desperately looking at every single macrophage, oftentimes kind of floating in the chambers, just hoping that we can find one yeast organism. But in this case, yeah, they really pop out of you. So this is a nice one.
Yeah, particularly on H&E, finding them right away and being so classic and easy to spot, it's very rare.
Yes. Yeah, in a lot of cases, we'll do our special stains. So we'll do usually a GMS stain or we'll do a PIS stain, hoping to highlight fungal organisms. Maybe we won't see any and we'll still suspect it could be histoplasma. So we'll recommend in those cases to still clinically assess for histoplasmosis because it's still a possibility and we don't feel comfortable totally ruling it out. All right, some cleanup. So here's our retina. It is detached, as I mentioned, likely due to this intense inflammatory response in the underlying choroid. It's a little bit folded up, but we do have atrophy of the outer layers of the retina. So this is the outer nuclear layer. It's just a little bit more thinned and less cellular than it should be. It's also lost its photoreceptor segments, so the little pink frilly frills we should see. And then, yeah, as I mentioned, our vitreous, just a lot of proteinaceous material. There are some floating cells, but most of this is just kind of protein. In some areas, maybe some fibrin too. This is in the subretinal space. But otherwise, our posterior segments are optic nerve. Optic nerve head looked fairly decent, maybe a little bit of residual inflammation in that peripapillary space, but rest of this looks quite good. Our lens also looks fairly unremarkable in this older cat. All right, so I will go ahead and move to diagnoses. So yeah, mostly pyogranulomatous inflammation affecting multiple aspects of this globe with the intrahistiocytic yeast that are morphologically consistent with histoplasma. So this is a dimorphic fungus. Typically, animals will be exposed to it via inhalation of the organism, sometimes through ingestion. It survives within macrophages, and that allows it to disseminate to other areas of the body, including the eyes. So typically when we see histoplasma in the eyes, we suspect that it does represent a manifestation of a systemic histoplasmosis, which in this particular case, they had said under general medical conditions, mast cell tumor and oral mass, most likely from histoplasmosis. So I assume they had strong clinical suspicion that this could be a mass associated with histoplasma infection.
Cat from?
This kind of, oh, good question. From Indiana.
Okay.
So good place.
No history of immunosuppression.
Not that we received, no. That is a good, yeah, the question was if there's a history of immunosuppression, which I have no idea. It's a good question because, yeah, there's a really florid infection in this particular case. Okay. There's no questions or concerns, okay. I'll move on to my next one. Classic cat diagnosis number 2. So this is the globe from a 12-year-old male castrated Maine Coon. And history we received, I'm gonna also redact some of this, but they said keratitis secondary to feline herpes virus in both eyes. And then they already suspected a particular condition, which is why I assume it was enucleated, but we'll withhold that for now. They said that this globe did not have glaucoma, and this problem had been going on since May 2017. Potentially, maybe that just means the keratitis has been going on since 2017. But it did sound like that they suspected that there was something else going on due to this kind of larger mass effect occurring in the globe. So this is the hemisection from this globe. It is a left globe. And we had described this kind of vague mass effect at the limbus, maybe extending into our cornea, as well as maybe the conjunctiva overlying it. This is our bulbar conjunctiva, and maybe a little bit of third eyelid. We're somewhat ventral in the globe here. And the clinical team also provided a really nice clinical photo for everyone to look at. Can't really see that mass effect, but we can at least appreciate that this cornea is not normal. There is quite a bit of vascularization. It's very hazy, very hard to see through. Some areas that do look a little bit thickened. And in this gross image, really not much else going on in the globe. I feel like it looks fairly unremarkable grossly. So normal lens, uveal tract, posterior segment looks immaculate. So just that corneo-conjunctival area. Okay, we move to the histology. And so here we go. See if I can rotate this to actually imitate how it was oriented grossly. Ooh, I'll try my best. Okay, so cornea is up top, and we have our optic nerve head back here, very cute in a cat. And here's our mass effect. It is kind of situated right at the limbus. So here's our sclera. We have some normal-ish cornea over here. So it's kind of right at that junction. It does extend a bit into the peripheral cornea, as well as maybe into kind of the more, mostly at the limbal sclera. And then perhaps it does affect a little bit of our bulbar conjunctiva as well. And here we have our third eyelid. We don't really have much gland, but maybe a little bit of cartilage. So we're kind of right at the periphery of that third eyelid. And as we saw grossly, rest of this globe looks relatively unremarkable. All right, similar situation. The globe's flipped 90 degrees. We have our beautiful mass. Here she is. This one's also fairly cellular, different cell population. So compared to our inflammatory mass in the previous case, this one is a rather homogeneous population of cells. And these are epithelial cells. Some things that perhaps lead us to include these could be epithelial. One, their shape, they're fairly polygonal when we can see their borders. Oftentimes they do have rather distinct borders. And then also their patterning. A lot of times they make these lobules. In some areas, we can have these more like trabeculae that are blending with one another. So this is an epithelial neoplasm, and it is exhibiting pretty infiltrative behavior. So we're deep in the corneo-conjunctival stroma. So I would call this a carcinoma. And accompanying it, there's also this desmoplastic stroma. So kind of this very loose, more pale basophilic stroma associated with it, which is oftentimes what we see with carcinomas, just a stromal response that's oftentimes accompanies carcinomas. And as we move around, let's see, got an area with less inflammation and necrosis. There's also a fair amount of nuclear atypia. So these nuclei vary quite a bit in their size and their shape. They have this more vesiculate chromatin. I guess I can go one closer. So this kind of like soap bubble appearance. And in some areas, there's also multinucleation, which of course is not popping up readily. If I see one, I will point it out. And there are some mitoses here, not many, but they are here and also rather bizarre. This does not look like a normal mitotic figure. And then the other thing that these cells are doing, oftentimes at the periphery of the lobules, they'll kind of have this more somewhat basilar appearance. So they have a small amount of cytoplasm. They're just a little bit more basophilic. And as we progress into the center of the lobules, they'll take on this more eosinophilic appearance with abundant cytoplasm. Sometimes they get very brightly eosinophilic. So they exhibit dyskeratosis here and there. Sometimes they develop these pycnotic nuclei. So infiltrating our stroma also, they're blending with our surface epithelium. So a lot of areas it's kind of hard to make out what's normal epithelium and what's this neoplasm. So again, also vamped long enough. This is a squamous cell carcinoma, which is really classic. Neoplasm will diagnose in the eye of cats. This is kind of a nice one that it does show the infiltrative behavior of some of these squamous cell carcinomas. As we move kind of more axially through the cornea, it is extending into the corneal stroma, not really contributing to much of a mass effect compared to over here. It's a little bit more insidious. Luckily, this one, sometimes these can be very infiltrative. They can infiltrate into like the orbital tissue and be really hard to remove without full extenuation. In this case, it looks like we did, or they did get it all out. So if we look at our margins, at least here, they look fairly clean. What's that?
Except for the meds.
All right, then just some cleanup in the cornea. There's quite a bit of stromal edema. Sometimes it's hard for us to say there's edema if it's seen clinically because it doesn't look quite as striking histologically. So like here's our normal cornea, but over here I'd feel comfortable definitely saying this is edema. It's very pale. We can see the separation of the stromal fibers. There's also vascularization, so tiny little vessels and quite a bit of inflammation. It's kind of mixed, mostly lymphoplasmacytic, some neutrophils here and there too. So all features that would definitely contribute to the opacity of this cornea seen clinically. And then there's a titch of conjunctivitis too, which is also fairly nonspecific. They mentioned this cat did have herpes virus. There isn't anything all too specific to herpes virus in this particular globe. Sometimes with herpes virus, we'll see little symblepharon kind of at the fornix here. And sometimes we'll see what we call conjunctivalization of the cornea, where we see conjunctival epithelium over the corneal surface, which in this case, I couldn't find anything convincing of that totally.
So think in a case like that, because conjunctivalization and atrophy and symblepharon might be associated with destruction of the stem cells of the limbus with a big tumor like that actually destroying the stem cells, the limbus.
That's true.
We might be hard pressed to attribute that to herpes.
For sure. Okay, and then everything else in this globe looks great, honestly. We don't see that many normal iridocorneal angles, so it's always nice to look at them. A nice reset for us. And then, yeah, back of the eye looks great. No evidence of glaucoma. Our retina is opposed. This one actually does have a normal outer layer. Beautiful. So really just the squame is going to be our major issue here. So yeah, we have our corneal-conjunctival squamous cell carcinoma, and then conjunctivitis as well as keratitis. Some of this could have just been sequela of that infiltrative squame. There's also concurrent herpes virus, hard to say how that contributed. In a lot of cases in cats that have squamous cell carcinoma will also receive a history of keratoconjunctivitis associated with herpes virus. To our knowledge, there's no direct link between herpes virus infection and development of a squamous cell carcinoma. Feasibly, just chronic inflammation could predispose to development of squamous cell carcinoma. So it's possible they're kind of indirectly linked, but there's no, direct connection to our knowledge.
Question for you about
Yes.
terminology.
Yes.
You used the word infiltrative to
Mhm.
describe this, and I've heard that with squamous cell carcinomas and Coplow cases,
Mhm.
but typically we reserve infiltrative for a round cell tumor, and this would be invasive.
Okay.
And I don't know if you guys have.
Never heard that.
Yeah,
haven't.
I haven't either.
Yeah. Infiltrative suggests that it's actually going in between pre-existing structures,
Hmm.
like spies in your
Mhm.
your organization
Mhm.
we have here. Oh, and but invasive means it's sort of destroying everything, and this is destroying everything. You can't
Yes, I
tell
agree.
what's there. And so my question was, is there a reason why you chose that versus the
No.
others? So
Semantics,
Yeah.
but no.
At least in the equine cases, it's named corneal stromal invasive squamous cell carcinoma. So
That's
that's
true.
pleased about that.
that's
So-
why.
And orbital invasive.
And orbital
Yeah,
invasive. Yeah.
so there you go.
There you
All right.
I guess it was there all along. The
Yeah.
clues.
Thank you.
Yep, thank you. All right, great. There's no other questions, concerns. I will hand over the mic to Dr. Clemens. Right.
Okay. I have no photos from actual cases today, just representative photos. This first case is one of my favorite types of surgeries and post-surgical complications. So we're going to talk about this for a bit. Keep in mind, especially if you are a surgeon watching this, all of the Coplow cases that are post-operative cases are like the worst possible because they end up in a jar, right? So don't think too badly of these surgical procedures based on watching Coplow cases.
Yeah, we have a very skewed
Yeah.
selection biased for cases that end up in a jar.
Indeed. So yes, there are studies out there that look at following cases up, including ones that don't get enucleated and can give you a sense of complications in general. So this particular case is going to be a 9-year-old spayed female in Newfoundland. The patient had phaco emulsification with IOL placement and prophylactic retinopexy in both eyes in 2020. She then developed retinal detachment in the right eye and had retinal reattachment surgery in 2021. Since then, left eye was doing okay, but right eye was slowly progressive corneal edema with bullous keratopathy, or at least corneal bullae developed, and associated recurrent corneal ulcers. And then several months ago, she developed glaucoma in the right eye. So we have the right eye in a jar. So when they say retinal reattachment surgery, what they usually mean is a procedure called silicone oil endotamponade in dogs. Essentially, the process involves taking out the vitreous. It's replaced with something called perfluorooctane, like a perfluorocarbon fluid, which is very heavy, and that sort of forces the retina back into place. And then the PFO, is then replaced by silicone oil, which is kind of light and like floats towards the back of the eye and tries to kind of keep the retina from redetaching, if you will. In humans, retinal reattachment is usually done with air, like a gas bubble. So if you've had any relatives that have had it done, they may have had a gas bubble instead. The reason why we can't do gas bubbles in dogs, even though they're kind of nicer, they resorb on their own, stuff like that, is that human patients that get that done have to lie face down for several days after the procedure, or else the gas bubble will shift and the retina may redetach. And we can't ask our dogs to do that. So silicone oil is used in some human cases that are a little bit more complex, or if you can't have the patient lie face down for several days. And so they're used in all dog cases because we can't have the patient lie face down for several days. The silicone oil is often removed in human cases in which it gets used on. So there's a separate procedure later on to take it back out again. In dogs, usually it isn't removed, and that's likely partly due to cost and partly due to patients having a shorter, lifespan than human patients. The, likelihood of complications starting up significantly, in a way that bothers the patient, maybe less, stuff like that. So usually it stays in long term in dogs. Some background on this really cool procedure. This is a representative photo. It's one of my favorites from the archives because you can actually see the retinopexy scars very easily in this patient. This patient had no lens, was essentially aphakic at the time, and you can maybe make out how everything in the eye looks kind of slick and slimy. Um, when we bisect these globes at the grossing stage, the silicone oil comes out as this very slippery and like very clear, like optically clear, and like viscous fluid. It's like glue. Yeah, it's like hot glue, yes, but not hot, yes, yeah. And then it sticks to everything, and then it makes your cutting board slippery for a little while afterwards. But it's a lot of fun. So, uh, so I may be the only one that enjoys grossing silicone oil cases. Um, and then this one is also kind of a neat representative photo because this patient had a desmetacele in the cornea. So this patient also had corneal complications like our patient. This cornea is kind of curving away from us, and you can see kind of on the back side of it, this thin spot in the cornea where the desmetacele is. So we'll talk about corneal complications associated with silicone oil and tamponade as part of this case. All right, that was a lot of explanation. See what we can do for subs. So you can already see a very purple cornea up top. This cornea is not necessarily happy. The IOL and the lens capsular bag have shifted during processing. They were in place at the growth stage, but here's our capsule. And our IOL doesn't always show up nicely. I can't actually remember if we'll find it in this one or not. We'll see. And then that's the main things to look at here. It's worth noting that at the grossing stage, we'll often describe whether or not the retina is still opposed to the choroid at least. We lose some of our context clues in terms of trying to diagnose retinal detachment or redetachment, if you will, in these cases, because stuff like RPE hypertrophy, outer retinal atrophy, things like that, could have occurred as a consequence of the previous detachment. So it's kind of all like, is it just that there are parts that failed to reoppose properly? Did it redetach after? Like, it's difficult for us to be sure. But at least at the grossing stage in this case, the patient still had a retina that was in its proper place. All right, we've rotated 90 degrees clockwise, and this slide is covered in dandruff. All right, it's still, hang on a second. Okay, I'm happy now. So the very purple cornea is a pretty significant keratitis. Let me get it in focus. We do indeed have areas of ulceration of this cornea, pretty bad. So pretty significant corneal complications. If we walk a little way over here, we see this interesting phenomenon. So between the epithelium and this really distinct anterior layer here, we have kind of this disorganized fibrous to fibrovascular tissue. So this lining here, this layer that's very distinct, is actually where the existing corneal stroma is at. And then there was extra tissue deposited between the corneal stroma and the epithelium. We call this anterior stromal remodeling. And it typically occurs in cases that develop corneal bullae or indolent ulcers. So those poorly adherent flaps of epithelium, kind of the space underneath fills in with extra stuff. So check, this patient had chronic corneal edema and recurrent bullae and ulceration. The findings in the cornea support that. And if we walk just a little way back, we can find the reason. So back here on the retrocorneal surface, we see the corneal endothelium. There's like a nucleus here, and then there's like nothing, and then there's a nucleus, and then there's these big gaps. And the endothelium also is usually a low cuboidal layer with a vacuolated cytoplasm. And in this case, it looks a lot more spindle cell. These cells are essentially even flatter and lower profile than they typically are. So this is corneal endothelial attenuation. It implies that some of our corneal endothelial cells have died and been lost. And this layer in dogs has limited mitotic capacity. It actually does have some mitotic capacity, but quite limited. So the healing process to that is usually just the remaining cells spreading out bigger and covering more area. So then we get this histologic appearance. It's a pretty non-specific presentation for any cause of corneal endothelial cell death and loss. So we can't distinguish like an age-related decompensation from an endothelial dystrophy. Or whatever else. But it was likely the reason for the corneal edema. Corneal endothelium is responsible for actively pumping fluid out of the cornea. Issues with endothelium can result in quite a profound edema.
those,
Oh, go ahead.
the endothelial cells, you said they look spindeloid, and 3D, is it squamous?
In 3D, they're always wider than they are tall. In this profile, they look almost like spindle cells, but yes, they are like wide, flat cells, like almost like a mosaic of tiles. Yeah, so they're
Would that
not
be
really.
metaplasia?
Yeah. I don't know if it's referred to as a metaplasia. Um, if you look at this in with like other forms of imaging, you'll likely see like the usual tends to look like a honeycomb almost, and then like injured endothelium will tend to have like gaps where some of the cells are lost, and then the remaining cells are just like bigger, or like variable in diameter. Um, there's this cute little area over here with a break in decimase with regrowth, which is likely a surgical site or a port site. You can see a little bit of disorganized fibrous tissue forming a tract here. Which sometimes that can kill a few endothelial cells, but it's probably not the reason why the endothelium is this bad off. So to find out the reason for that, oh, go ahead.
So yeah, just going back to that, one way the corneal endothelium reacts, like when there's corneal endothelial loss, which is endothelium, some misnomer because that's an epithelial. So they
Different
lose that
physiological
honeycomb
region.
appearance because then they're postmitotic. So theoretically postmitotic.
It varies by species.
So the main way it responds to loss is by stretching out to fill up the gaps. So you end up with cells that are flatter looking even more so. And that's why you end up with increased distances between the nuclei here and even flatter looking cells that on a cross section might look even spindle, but it's just like them reaching out.
Yeah. They're not really a spindle shape in reality. Yeah. They just look that way. So if we zoom over here to the aqueous outflow pathway, we do have a bit of a ciliary cleft still here, although the ciliary cleft and trabecular meshwork are often pretty narrow to collapsed in this case. If we look really close at the ciliary cleft and trabecular meshwork, we have all of these coalescing, clear, sharply demarcated spaces here. Very sharply demarcated, clear bubbles. And they're all coming in through the aqueous outflow pathways. And actually, this one's kind of cool in that if we look next to that, out here in the sclera, clear, sharply demarcated bubbles, and out here in the episclera / subconjunctiva, we have more of these clear bubbles. And out here, there's maybe a few macrophages associated with these guys here and there, but they're pretty inert. This tissue or this not tissue, this material is pretty inert and doesn't really provoke a ton of inflammation. Maybe a few foamy macrophages trying to phagocytize it here and there. So these clear gaps are the spaces left behind by either silicone oil or leftover PFO. We can't really tell the difference between those two things histologically. Theoretically, PFO is more likely to be ventrally dependent, so more likely to be found ventrally, and silicone more likely to be found dorsally, but we can't really tell the difference on just a slide. Theoretically, also, the PFO will be removed during the procedure, but it's possible for some to be left behind. So what this represents, though, long story short, is migration of that material into places that we don't want it to go. It's supposed to stay in the vitreal space, and sometimes it migrates elsewhere, and including it can essentially emulsify. So like the big bubble that's meant to sort of stay in the vitreous and stay back there can become like many tiny bubbles, just like salad dressing. And it can end up going places that way to some extent. So it can go into the anterior chamber, and then it can go into the aqueous outflow pathways and contribute to glaucoma onset, which is likely what happened in this case. We will sometimes see migration into other structures, in this case through the collagenous tunic, apparently, and into the periocular tissue. Some of that may happen because it happened via an incision site, and we just didn't quite catch where it's coming out at the incision. But the silicone migration can be a little bit mysterious. It's not quite known like what mechanism is causing it, and it may be facilitated somewhat by macrophages. Like there's some ideas out there. So like we see it in weird spots, basically. The really wild ones are sometimes we'll see it migrating into the optic nerve. And there's been description of some cases where silicone has migrated as far back as the ventricles of the brain. So that's wild. So Silicone oil migration, and then because the silicone oil likely got into the anterior chamber in this case, not only did it likely contribute to onset of glaucoma in this patient, the silicone oil can be endothelial toxic, so it can cause damage to the corneal endothelium and can result in corneal complications when it comes into the anterior chamber like this. So it may have played a role in this patient's onset of corneal disease as well. So there's that. I'm not going to spend much time on the other stuff because I will have taken a lot of time already. If we go back to the retina really quick, we have this little nubbin of peripheral retina where we have a little rounded end, rounded and atrophied. So this is an example of a retinal tear, which is likely why they did the retinopexy in the first place. So the retina was torn at some point. Actually, we can probably just walk this way. And sort of next to that, we do have this area where the retina is essentially undergone full thickness atrophy. I can't really make it out at this level. And there's additional collagen that's kind of been deposited along the choroid and may even be kind of replacing some of the more normal choroidal stroma. And this is what we sometimes will see for retinopexy scars. This is likely a consequence of retinopexy. And then here the retina is coming back in. We can see maybe a bit more of that kind of sharply demarcated spots, like over here, for example. Not bad. So again, kind of areas where we have this sharply demarcated atrophy of the retina, which is kind of likely a consequence of retinopexy. Although some of the retinal atrophy could also just be a consequence of previous detachment. So that is this case, which is probably taking up a ton of time. So here's some stuff about this case. Does anyone have any questions about silicone oil endotamponade and complications thereof? All right. Should I skip my next one? I feel like I could just skip. Okay, all right. I was expecting this to take a ton of time, so I was all like, I could always just skip. Okay. Back to the cat theme once again. So we have a 9-year-old neutered male domestic short hair cat. This is not that cat's globe. It's another representative photo. But maybe something like what this would have looked like grossly. For this cat, they describe a comfortable eye, but let's see, there is the left eye, which is the bad one, is slightly larger than the right eye, they say. There is a centrotemporal focus of corneal fibrosis and a large anterior synechia to the site, so they suspected a sealed perforating corneal injury. And a cornea, perhaps, or the eye has an overall fleshy appearance, which is a fun description. They say diffuse cataract preventing fundic exam, and this eye had glaucoma as well. So on a cut surface, the globe is full of this tan tissue. And we can't really make out much of a lens. It's either that it's kind of collapsed or resorbed or just sort of lost amongst this tissue. It would be kind of hereish, but we can't really see it very well. The uvea is also pretty distorted by this tissue that's infiltrating the area. So that's it for our representative gross photo. Let's go straight to the still. Can't decide which slide I want. All right. Probably doesn't matter. Any slide will do. So here is a subgross of our actual eye. In this case, we probably would have seen the lens a little bit better than our representative gross photo grossly. We do still have an intact nucleus here. But the capsule we can see extending out over here. And there's a lot of space between the nucleus and the capsule. The cortex is essentially gone or resorbed. And then we have all of this purple tissue, which was once tan on the gross, perhaps, in the iris and the ciliary body and kind of carpeting surfaces along the choroid. And we have these weird like bump lumps along the back of the cornea too. So let's see. Chaos. All right. Don't think this one was maybe I picked poorly. No, okay. Nope, we chose poorly. All right, we'll come back to that. We'll come back to that. Let's not ignore the elephant in the room. So we have this huge, um, highly cellular tissue that is essentially effacing the uvea, pretty well circumferentially effacing the anterior uvea. We can make out some ciliary body plicae in some areas. We have this tissue that's kind of lining parts of this lens capsule, and it's lining a detached retina through here. We have our remaining lens nucleus here that is lined by all of this fun stuff, which we'll look at closer in a second. And we'll do a quick tour around the eye to show how it's distorting the choroid as well. Carpeting surfaces and kind of variably invading and effacing the uvea. We look closer at these cells. They're spindle cells. They're arranged into intersecting streams. They are interdigitating with collagen. In some areas, they're interdigitating with this sort of brightly eosinophilic collagen, which is interesting. And they're maybe forming kind of like regularly intersecting layers. As you get close to the lens, sometimes it's mostly just collagen. You can see the same population carpeting the inside of the lens as well as the outside. And you see a ruptured end of lens capsule right here, just embedded in these cells. So we have a lens capsule rupture. And in addition to that, here we go. A lot of this chaos along the remaining nucleus is macrophages that are lining and starting to phagocytize some exposed lens fibers. So this is a lens capsule rupture, and there's a neoplasm that is on both sides of the lens capsule and has extended out and is starting to efface structures inside the eye. So if you haven't already guessed, this is a post-traumatic sarcoma in this patient. Let's see, I feel like I chose poorly. I'm going to switch to another slide. Some interesting features about this one. So they said that there was a nice little paraxial or centrotemporal focus of corneal fibrosis, which at a deeper level here, we're kind of getting into that a little bit. The cornea is a little bit more disorganized here paraxially. And then we have Descemet's membrane, which is broken and just kind of dangling off in this direction. And this purplish tissue is most likely really, really distorted iris that has just been overtaken by this neoplasm, and is extending towards that break in Descemet's and kind of fuse into that site. I still think we're not quite right at the level of a defect, but we're probably at least closely adjacent to what they called a sealed corneal perforation. And I would agree that's most likely what this is. A site of a corneal defect that's been filled in and which had an anterior synegia to the location.
Megan, go lower magnification and just show the the pigmented uveal tissue. So we kind of take it for granted because our brains go there right away. But if you guys follow the pigment on these distorted globes, you might have a good idea where the original uveal tissue is, and I think that's why Megan's suggesting that was iris.
Probably. Artist formerly known as iris.
Yep.
Yeah.
Exactly.
You can make out more of the ciliary body
Exactly.
plicae than the iris, really. Like this is where the plicae used to be.
It's the practical thing for people there.
Yeah, in fact, you can even see the double layer sometimes embedded amongst the neoplastic cells. Yeah.
Not that it matters diagnostically, but sometimes as pathologists, especially residents or trainee, you get something like that and you get overwhelmed by how you cannot identify anything. So putting pieces together and finding your anatomical boundaries is useful.
Find your landmarks, yes, absolutely. There's a few other interesting features on this case. So right here along the anterior iris, there's this site, which is starting to look like cartilage. So we have this kind of glassy looking stroma or extracellular matrix, and then the cells are kind of rounding up in these little like gappy areas that look like lacunae. So it's kind of like a chondromatous differentiation or chondromatous metaplasia sitting here. And I was debating whether some of this pink stuff could be osteoid. Let me see if I can find anything that looks halfway interesting, but
Like that.
maybe. What do you guys think? Osteoid, maybe? Hard to be sure. It could just be collagen that is not osteoid. But So this could possibly be one of our kind of osteosarcoma, chondrosarcoma type variants of post-traumatic sarcoma, which is a pretty rare variant. But that's kind of just one of the neater features. Otherwise, this is a pretty classic post-traumatic sarcoma case in a cat, which is a tumor of lens epithelial origin. So it probably started around the ruptured lens and then spread out from there. And it tends to take place after a trauma in a cat that ruptured the lens. So in this case, most likely what happened, we had a penetrating trauma that involved the cornea and the lens, and then the tumor eventually developed a ways after that. So that's our other case. Any questions? Okay, I will finally yield the floor with very little time left to Gillian.
Alrighty, hello everyone. I will present an eye from a 6-year-old Australian Shepherd. Came with a history of this globe has been abnormal since birth. Remember, this is a 6-year-old dog. They say severe congenital eye defect. Time of evaluation, at the time of evaluation, the globe is glaucomatous with a deep anterior chamber, no visible lens, no visible iris, possible hypermature resorbed cataractus lens in deep posterior chamber with scarring, difficult to determine. The internal eye shows severe posterior segment scarring. So, yes, I think we can agree with that. So, up at the top here is the cornea as usual. From here to here, and I can say that because I've seen the slide, is the posterior chamber. So somewhere up here, there is an iris. So they said the iris was difficult to see, but I'll show you it's very obvious histologically. Probably the pupil was very dilated, and therefore the iris was difficult to see clinically. So what we have is a very stretched out posterior chamber. And what we also have is a very foreshortened posterior segment. Another thing that we can see grossly is that there's no obvious lens up here in the posterior chamber where it should be. There is this sort of accumulation of dense white tissue at the back of the eye. Also, when you follow the choroid here, well, ciliary body, leading into choroid somewhere, it is then suddenly discontinuous here. We also couldn't really identify the optic nerve head grossly. And we didn't actually take note, but I imagine it was somewhat difficult to identify the optic nerve on the outside of the eye. So with all of those things in mind, let's go ahead and jump into the histology. So here's the cornea off to the left. And as I said, here are those iris leaflets. So it is a little bit weird that it was so difficult to see it clinically. One thing we can see, well, it's hard to see at this mag, so I won't go there. Anyway, so here's some of the ciliary body plicae. So this posterior chamber is like massively expanded. And then we get back here and there's actually a defect in the sclera. So there's some sort of scleral rupture or congenital abnormality there. So we have some uveal tissue kind of wrapping around here and kind of extending out. So here's sclera where it ends. So we have uveal tissue wrapping out and around. There's some disorganized collagenous material in that gap. And then when we look higher mag, I'll tell you that this is the lens capsule. And I think this is another segment of it over here. And there was mineral in here on some of the sections. I did several deeper sections of this one just to see if I could actually find the optic nerve head. And I never actually found it in the 3 deeper sections that I did. So we'll just ignore that extra slice. And now we'll go higher mag. All right. The cornea itself is kind of unremarkable. This is artifactual fragmentation of Descemet's membrane. Oh man, hold on. Come on. Isn't that dirty upstairs? All right. Ugh. All right, just ignore that shmoo here. What is interesting is that Descemet's membrane tapers and it kind of extends past where I think it should be. So I think the limbus, which is where the cornea meets the sclera, is here and it's kind of stretched out. And Descemet's membrane continues on beyond that. And it comes right on down here. Here we have some of the aqueous humor collecting channels. So the base of the iris is, in my opinion, posteriorly displaced. Or at least it feels like that. Either that or the limbus is truly stretched out. It's kind of hard to tell. So, and then the corneal endothelium and Descemet's membrane continues there beyond where I think it should. So I think there's somewhat of endothelialization and descemetization, which is when you have migration of the endothelium and it continues to elaborate Descemet's membrane, sort of around that ciliary cleft. So we have no discernible ciliary cleft here. The trabecular meshwork is also difficult to identify. In my opinion, there could be two reasons for this. First of all, this could be blunt trauma that led to cyclodialysis, which is when the ciliary body gets ripped away from the sclera. And then as that sort of heals, you get this sort of abnormal relationship of the base of the iris to the sclera and the limbus sort of. Or this could be a congenital abnormality. So this iridocorneal angle could have never been normal congenitally, in which case I'd probably suggest this is more similar to what we call anterior segment dysgenesis / gonio-dysgenesis, but probably more similar to ASD or anterior segment dysgenesis. This globe continues to have a bunch of other stuff going on though. So let's move back. As I said, this entire area is posterior chamber. And so all of this uveal tissue here is ciliary body. And here we can see those ciliary body plicae. As we move back, this is choroid, and as I said, it sort of wraps around that end of the sclera. Out here we have pigmented uveal tissue that's sort of mingling with this collagenous tissue. So this is fibrosis. We also have what is immediately adjacent on the inside of the eye is lens capsule. So it is doubled here and tripled. So we have definitely a cataract. And I think there's lens capsule rupture. I can't remember exactly where it was. The lens does contain, and in other sections, contains some mineralized material. So here's some of that here, which probably made sectioning this eye particularly fun for our histotechs. Anyway, here we are in that gap in the sclera, and what we have is some pigmented cells. So this could be uveal tissue that's kind of fragmented, and then what we also have are these islands of sort of amorphous neural-like tissue, which I think are probably the remains of retina, very atrophied retina. One could also argue that so let me back up. There's a gap in the sclera. This could also be due to blunt trauma and scleral rupture. This could also be due to a coloboma, which is the congenital absence of a tissue where it should be. So in that case, it's possible that the retina, if this was a coloboma, this retina could have never been normal if there was like severe developmental abnormalities in this eye. So this could be either very atrophied retina or like congenitally abnormal retina. The lens itself is ruptured and there's a really significant cataract. I'm not sure if this is a congenital problem or a traumatic problem. So long story short, this globe has some really interesting lesions, and I have no idea if they're truly congenital versus traumatic. Or both, yeah. If they were traumatic, they are more consistent with blunt trauma and not penetrating trauma. And so yes, this could also be a congenitally blind eye, or one that, for example, developed glaucoma very early on, and then because it was a blind eye, there's more of a chance of suffering blunt trauma or any kind of trauma, when you can't see. So anyway, it's just a really interesting case. And it was really interesting that the clinician really honed in on a congenital problem. And when I look at this, I'm like, well, I don't know what it is, but it's weird. So I think this could be either or both, as we just talked about. So, that is the gist of it. So this one, like many of our cases, just has a huge laundry list of problems, but abnormal since birth per history, hypermature cataractive lens capsule rupture and posterior lens luxation, posterior scleral defect. And I wasn't sure if that was traumatic rupture versus a congenital abnormality. Oh, I think when we went higher mag, there were discontinuities in Descemet's membrane, which could have been due to blunt trauma, or they could have also been due to Hobbs striae, which is stretching of the eye, due to buphthalmos, which is usually associated with glaucoma. And I can't remember if they said yes, glaucoma in this case, but anyway, so that collapsed ciliary cleft and trabecular meshwork, I wasn't sure exactly what the cause of that was. Oh, and then the other thing is that there was posterior extension of the conjunctiva in our extra slice over here. So here's the limbus, and the conjunctival tissue extends way back here. So we see this in globes that have been proptosed. So I almost wonder if this globe suffered proptosis at some point. And that, yeah, and then popped back in later or something. Anyway, so that was another interesting thing I forgot to point out. And then glaucomas per history, and I couldn't really tell them whether it was secondary or primary. I will not rush the last case that I have, so I think we'll just wrap up there. So any questions or anything? Okay, great. Thank you very much for your attention.
Thank you.
I hope you have a lovely day, and we'll see you in 2 weeks.
Thank you.